bác sĩ Phi nha.
Dạ vâng, em chào anh ạ.
Ừ, cảm ơn Phi đúng không?
Dạ vâng, em Phi ạ. Vâng ạ.
Cảm ơn đã tham gia nha. Mình là Doãn Đào á.
Dạ vâng, em chào anh. Em
Rồi,
thấy và Hằng tham gia góp vui, nhưng mà hỏi Hằng là gần như tham gia như thế nào. Hằng bảo là cứ tham gia thôi, em cũng không biết là thì tham gia như thế nào. Tôi cứ 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 xem là mọi người cần trao đổi gì thì chúng ta trao đổi thôi. Vâng.
cái này như một cách trao đổi vui vẻ và không có gì phải quá formal á.
Dạ vâng, tất nhiên em cũng biết. Vâng.
Với một cái diễn đàn để mọi người đến chia sẻ vậy.
Vâng. Anh Đào đúng không ạ? Doãn Đào đúng không ạ? Vâng. Anh Đào ở bên đó là làm về 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 thấy Hằng bảo là anh cũng chuyên về tiêu hóa đúng không? Chuyên tiêu hóa và liên quan đến đến rượu đúng không?
Mình thì làm tổng quát thì tiêu hóa gan mật, nhưng mà nghiên
Vâng.
cứu á, thì tập trung vào viêm gan B và ung thư gan.
Về ung thư gan. Vâng.
Bạn speaker hôm nay là cũng trong khoa của mình, Victor.
Vâng.
Thì bạn này tập trung về gan do rượu á.
Vâng.
Ừ.
Cái đó thì điều trị ở Việt Nam còn chán lắm, còn yếu lắm.
Ừ.
Thế là về 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 gan gan do rượu thì em không nói, tất nhiên là ở đó thì các bác tiêu hóa làm, những các vấn đề liên quan đến 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 rượu là Việt Nam bây giờ là rất là là kém, bởi vì cái việc mà điều trị nó chỉ tập trung vào vấn đề gan mật, thì sau rồi về lại bệnh nhân lại 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 uống rượu lại, cho nên lại tái phát. Cái vấn đề ở đó ở ở bên 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 Mỹ giải quyết có tốt không anh?
Mình nghĩ cũng tương đối thôi à.
Dạ.
Cũng còn nhiều thứ để làm lắm.
Vâng.
Ví dụ như về việc chữa trị thì phải cần một cái đội ngũ nhiều
Đa
chuyên ngành,
ngành.
đa
Vâng,
ngành.
đúng rồi. Ở Việt
Ờ,
Nam thì không có cái đó, nên đâm ra là cũng là cái khó nhất là đội đa ngành, bởi vì không có cái đó là cũng không có được, không có
đúng
làm
rồi.
được.
Có
Việt Nam
thể
nó không.
cho họ xuất viện một lần, nhưng mà cái này là một chứng bệnh luôn á, thì họ cứ tái diễn vẫn uống rượu sau khi mà xuất viện.
Vâng, vẫn vẫn uống uống luôn, uống uống liên tục.
Ờ,
Dạ em xin phép anh Doãn để em chiếu cái video chờ để em mời các quý bác sĩ người ta vào á.
ok, chào
Như cả
à,
Dạ, hello
hiện.
cả nhà. Ủa Victor chưa vào à anh Doãn?
ừ,
Hello
chưa thấy
Kitty.
nào.
Rồi, chết.
Hello bà.
Ừ.
Attendee cũng có một vài người tham gia rồi ạ. just joined us. Morning, Victor.
What's that?
Good morning.
Oh, morning.
Morning.
No, because I'm
Good
actually
evening from Việt Nam.
I'm like sharing two accounts because it's easier. I just I found that sometimes my connection drops off, so I do this just in case one of them disappears, and then I'll still be okay.
I'm sure.
You are very careful.
You look sharp this morning, by the way.
Uh,
I think this is my first time seeing you in formal wear.
Interesting.
Hi guys, one minor question. Do you think that my presentation should be in Vietnamese? Hello everyone, welcome you to our Liver Talk today. I'm Associate Professor Đào Viễn Hằng, coming from Internal Medicine Department of Hanoi Medical University. And today, welcome you all to our Liver Talk with a very hot topic, alcohol liver disease. So firstly, I would like to introduce Dr. Doãn Đào. Maybe all of you are very familiar with Dr. Doãn because we have 3 previous episodes of Liver Talk. Dr. Doãn is the director of the Center of Excellence from Johns Hopkins in the liver disease, and he has so many collaborative research in Vietnam. And one of the priority is about research and education. So that is why Liver Talk was born and is the forum where the Vietnamese doctors learn a lot of experience from US doctors. So please give some brief speech, Dr. Doãn.
Great. Thank you, Associate Professor Đào Việt Hằng. It's a privilege again to reconvene through this episode of Liver Talks. As introduced by Professor Hằng, our topic today is about alcohol and liver disease. I think it's really relevant. And of the speakers, we fortunately have Dr. Victor Cheng, whom I will introduce in a few minutes, and our lovely, pretty popular and famous moderator, Professor Hằng Đào. And we also are fortunate to have to welcome Dr. Phi, whom will be introduced by Dr. Hằng in a little bit. Dr. Victor Cheng is an assistant professor of medicine and a transplant hepatologist at the Johns Hopkins University School of Medicine. He obtained his medical degree from Emory University School of Medicine before he went on to complete an internal medicine residency at Duke University Medical Center. And subsequently, he came to Baltimore to perform his gastroenterology and transplant hepatology fellowships at the Johns Hopkins Hospital. Recently, while he was pursuing medical practices, doing research, having a family with children, he was studying for a Doctor of Philosophy in Clinical Investigation, as well as a certificate in public health economics from the Johns Hopkins Bloomberg School of Public Health. That's amazing, and he's one of those whom I really admire and aspire to be. For his research and career development, he serves on both the Practice Guidelines Committee and the steering committee of the Alcohol-Associated Liver Disease Special Interest Group for the American Association for the Study of Liver Diseases, or AASLD. His research has been supported by the U.S. National Institute of Health, which is really the gold standard when you do research and getting that support from the NIH or the National Institute of Health. And he studies the intersection between alcohol-associated liver disease, alcohol use disorder, and liver transplantation. His work and his team's work have stimulated national conversations to make people rethink about the management of alcohol-related liver disease nationally and to some extent internationally. So with that, I would like to formally introduce Dr. Victor Cheng. And before Victor come to the podium, I'd like to acknowledge the support from the Institute of Gastro and Hepatology in Hanoi, Vietnam, and the Vietnam Viral Hepatitis for organizing this event. Thank you again.
Well, thanks so much. Thanks so much, Dr. Dow, for the very kind introductions. It's a huge pleasure to speak here, at this event, and I would like to take the next 30 minutes, next half an hour or so, talking about this topic, which really has become it's a very important topic already, but it's become a very central topic to what I do, and something that's really that means a lot to me. So if it's okay, I'm going to share my slides. All right, thank you so much. So today I am tasked to talk about alcohol-associated liver disease, and the talk will focus on some of the emerging concepts in its diagnosis and the management. And along the way, I'll hopefully point out some areas that need further research, further investigation. These are my disclosures, some research grants, and advisory board for AASLD. So the objectives today. I hope to cover these 4 topics. I want to first go over some of the public health implications of alcohol-associated liver disease. I'm going to abbreviate it as ALD from here on for the rest of the talk. We will go over some of the describe its disease spectrum, diagnosis, prognosis, talk about some medical therapies, and we'll briefly touch on liver transplantation for alcohol-associated liver disease, recognizing that liver transplantation has a lot of societal implications. So I fully recognize that what we do in the United States may not always be 100% applicable to different nationalities. So once again, public health implications of ALD. Alcohol-associated liver disease is a big deal. It accounts worldwide about half of all cirrhosis-related death. And the data I'm showing here is United States. It's from the US, from CDC in the United States. And it shows that for over a decade, alcohol has been the leading cause of cirrhosis-related death, with an annual growth about 3% a year up until 2016. And I'm going to show in a few slides that statistic actually changed a lot during the COVID pandemic. But at least up until 2016, it was rising about 3% a year, whereas or NAFLD, or what we now call MASL, grew at that point about 12% a year. But if you draw the lines out using these statistics, it would take about until 2045 for NAFLD to actually catch up to alcohol-associated liver disease based on pre-COVID statistics. Now, unfortunately, cirrhosis-related death has been rising also in the past decade. And once again, using CDC data, it is pretty clear here that if you look at the different age groups, the majority of that increase has been driven by the youngest adults, ages 25 to 34. And a lot of that increase has been driven from alcohol-associated liver disease and alcohol use disorder in general. So during the COVID pandemic, unfortunately, we saw a lot of reports of increased alcohol use. And these are some reports earlier on during that first year, 2020 and 2021. I'm showing here 2 different studies from social media and just email surveys. These are public surveys. The first study here, mentioned that compared to pre-COVID-19, respondents in mid-2020 described that they had, or 60% of the respondents described that they were using alcohol more than before COVID-19 started. And same thing here, in a different survey, once again, there was an increase. The respondents reported more drinking compared to 2019. And on average, there was an addition of 0.7 days from already a baseline of 5.5 days a week. A lot of that increase was reported by women. Now, fortunately, this increase in alcohol use seemed to have returned to pre-pandemic levels by middle of 2021. Now, this the data that we show here is this is our study here at Johns Hopkins that show that early on during the pandemic, not only did we see the increase in alcohol use, but it was now starting to translate to increases in liver disease, severe liver disease. So the data here is our regional data in the state of Maryland and the surrounding states, showing that at the very top, those who are hospitalized for liver disease, the orange line above is the orange line at the very top are those with ALD and recent drinking within the last 6 months. So this is not someone who's already had long-standing liver disease and came to the hospital for something else, maybe like an infection or something. No, this is someone who had alcohol-related liver disease, but also was recently drinking, and we believe that rise was due to the increase in alcohol use during the early parts of the pandemic. A different study, once again from using the CDC data, showed the comparing the observed and the predicted death before and during the COVID-19 pandemic. And if I can just use a pointer here. So you can see how the dark blue triangle and the light gray here, these are areas that represent excessive mortality compared to the trend based on the predicted trend based on pre-COVID-19 pandemic. And you can see here, both alcohol and MASL or NAFL had an increase, whereas viral hepatitis had somewhat of a decreased predicted mortality during the pandemic. And that increase was particularly vivid for ALD, to the point where the increase will, I had mentioned before the pandemic, the increase had been somewhere around 3.5% increase a year. But during the pandemic era, the increase was closer to 17 to 20%, depending on what exactly how you define mortality. And along with increased severe liver disease and increased mortality, you wouldn't be surprised then to hear that during the COVID-19 pandemic, we also saw increase in waitlisting and liver transplant for alcohol-associated liver disease. And this is, once again, data from the United States. This is the UNOS database, or our national transplant registry, showing that the increase began pretty much at the, starting from the beginning of the COVID-19 pandemic in March 2020. And unfortunately, due to all of this, a simulation study that came out in 2022 anticipates, as a result of the pandemic, that over the next 20 years, we're going to see an added 8,000 ALD-related death, added 18,000 cases of decompensated cirrhosis, and over 1,000 cases of HCC. These are all additional, extra cases on top of what we already expected to see. And that's based on, this simulation study is based on just that 1 year increase in alcohol use. So this is not, which is what we've seen. This is not based on thinking that the alcohol use would be sustained. And they actually did, the study actually showed what would happen if the alcohol use sustained beyond that first year. And as expected, these figures were even higher. But as we mentioned earlier, it seemed like after the first year, alcohol use did return to pre-pandemic levels. And despite that, we can expect to see many more cases of liver disease in the next 20 years. So with that, I will go over to the disease spectrum part of the talk. But before we talk about alcohol-related liver disease spectrum, I think you can't talk about ALD without actually talking about alcohol use. Now, one challenge of doing alcohol research internationally is that there's really no consensus in what one standard alcohol drink means. And actually, some countries may not even have adopted a standard drink definition. So in this one study, the authors looked at 75 countries, but only found definitions for a standard drink in 37. So about half of the countries actually had a standard drink definition, at least that the authors were able to find. The most common definition was 10 grams of pure ethanol, but you can see here the range was anywhere between 8 to 20 grams in Austria. In Vietnam, one standard drink is 10 grams. In the United States, on the other hand, one standard drink is 14. And there are a lot of cultural reasons why the standard definition is different, and often follows what the most common sale of the most commonly purchased alcohol beverage, whether it's beer or wine. It often follows what the most common, what's most commonly sold beverage is in that country. And I think there's probably also some difference between how the United States uses the imperial system, whereas the rest of the world uses the metric system. That probably has something to do with it too. But what are these drinking levels? Well, we like to think of alcohol use by binge drinking and heavy drinking. Binge drinking is a very standard definition that really is based on what the amount of alcohol use and how quickly using alcohol would you get somebody to a baseline or a blood alcohol level of 0.08%. And in the United States, that's considered the legal definition for being drunk or intoxication. And it turns out that for the US definitions of 14 grams, that comes out to be about 4 or more drinks for women or 5 or more drinks for men within 2 hours. And the NIH has defined heavy alcohol use as this is more of a chronic definition, that on average for women, more than 3 drinks a day on any given day, or on average, more than 7 drinks per week. For men, it's more than 4 drinks a day on any given day, or on average, more than 14 drinks a week. Another one of our U.S. societies does define slightly differently, and using binge drinking for more than 5 days in the past month as a definition for heavy alcohol use. So the definitions here for heavy use or chronic use also differs a bit depending on where you look. And of course, for international research, we need to remember to convert this to the definition for standard drink based on the country's definitions. So it probably would be easier to work in grams of ethanol, just knowing that most consumers and most patients don't think in grams of ethanol, they think in number of drinks. For alcohol-related liver disease, we can expect a natural history, for the most part, very similar to other liver disease with a few exceptions. So most people will start out with a normal liver, but with 2 years of drinking more than 60 grams of alcohol every day, you might expect more than half, and really probably closer to 100% of people developing steatosis or fatty liver. The good thing is, if that's where a patient is, you can expect some of that reversal within 4 to 6 weeks of complete alcohol avoidance. But if drinking continues, then about 10 to 20% of patients will develop scarring, fibrosis, and cirrhosis. And where alcohol-related liver disease is a little bit different from many other liver disease processes, is that it's possible to independently, without going through cirrhosis, to develop what we call steatohepatitis, or an acute inflammatory syndrome of conditions that actually look a lot like decompensated cirrhosis, but there may not be long-lasting scar tissue within the liver. Now, epidemiologically, though, having said that, epidemiologically, it has been shown that by the time someone has very severe steatohepatitis, and I'll define severity in a few slides, but once someone develops severe steatohepatitis, more than 75% of the time, they do have cirrhosis underneath. It does make someone more likely to develop the acute inflammation. But at the end of the day, they all join together to cause decompensation, which we define by the onset of ascites, GI bleeding, jaundice, and confusion, encephalopathy. And finally, about 3 to 10% of patients with cirrhosis can develop hepatocellular carcinoma every year. The risk factors for ALD are, myriad. So female sex is more likely to develop ALD, mainly because of 2 reasons. Women have less gastric alcohol dehydrogenase, which is essential for getting rid and processing some of the alcohol before it even reaches the liver. So women, having less gastric ADH does make that a risk factor. And women also tend to have less body water than men of similar weight, which means that the average blood alcohol concentration tends to be higher. Genetics can also play a role in ALD. And we know that about 50% of the risk for alcohol addiction is accountable by genetics. And this is there have been many family and twin studies to account for that. But even after someone develops alcohol addiction, alcohol use disorder, some mutations in alcohol dehydrogenase and acetaldehyde dehydrogenase and PNPLH3, these are some examples. They can make somebody more likely to develop liver disease. We also know that having other diagnoses, other liver disease, makes someone's more likely to develop or to be more susceptible to alcohol. So we have studies now in concurrent hepatitis C, concurrent MASL, or again, what we used to call NAFL, and definitely someone who already has cirrhosis. There's really just no safe level of alcohol use. And when someone has cirrhosis, we just recommend zero alcohol use, period. And finally, we are now seeing some hints that people who undergo obesity surgery, gastric bypass surgery, are also more likely to develop alcohol-related liver disease. And we believe that's partly because, again, the gastric alcohol dehydrogenase, many of the bypass surgery cuts out or eliminates a big part of the stomach surface area, so you have less of the capacity to process the alcohol before it gets into the liver. Diagnosing alcohol-associated hepatitis has traditionally been quite challenging. And the AASLD recommends this paradigm, basically saying that most of the time you can probably get at the diagnosis with clinical definitions without, as long as you don't have any potentially confounding factors. But if you really, really want to know, you can definitely, you can achieve a definite diagnosis with a biopsy. It's just not required to achieve that diagnosis. So what I mean by clinical diagnosis, what do I mean by potential confounders? AASLD does give these definitions here for clinical diagnosis. Basically, they're based on timing of the jaundice compared to the previous alcohol use, how recent alcohol use was, and certain biometric biochemistry parameters. Some of the confounders, on the other hand, are just liver diagnoses that can sometimes look similar, including some diagnoses like ischemic hepatitis, Wilson's disease, drug-induced liver injury. If there's no chance of these other diagnoses, then you can be pretty certain that someone has alcohol-associated hepatitis if they meet the clinical parameters above. So I mentioned earlier that it's important to define the severity of disease. The last two slides, those were about defining or diagnosing alcohol-associated hepatitis. But once you make that definition, you now need to know how severe it is. The most common, most old school definition for alcohol-associated hepatitis is the discriminant function, or we often call it the Madry's discriminant function. This is a study or a instrument that's very important to us here at Johns Hopkins because it was designed here. As you can see, it now has almost a 50-year history. It has been the most validated of all the definitions, where a MDF above 32 implies a 35% 1-month mortality. And you can see that those who had less than 32, the mortality risk is less than 10% at 1 month. But there are now other models. A very popular one is the model for end-stage liver disease, or the MELD. It traditionally contains 3 elements: creatinine, normalized ratio, bilirubin, and more recently, there's an addition for sodium. And there's even a more recent one, the MELD 3.0, but that hasn't been shown to be as good for alcohol in a very recent study. So that's why I'm not mentioning it here. There is now also a dynamic model called the Lille model from France that differs from the static models in that it provides the opportunity to look at bilirubin in day 7 to define whether or not someone is doing well on treatment. Now, if someone is not responsive to treatment, they have a very poor survival risk at 6, or a chance of mortality risk at 6 months. There are even more prognostic models here that I won't spend a lot of time going over, but I just want to show that there have been many of these in the published literature. They're mostly not in mainstream use. For a variety of reasons. It could be because it's just too complicated. It could be that it's not much better than the MELD score, a number of reasons. And then, this particular score here requires a liver biopsy. So, of course, it hasn't been as popular. it's important to know that you can actually improve the clinical prediction for how someone is doing, especially how someone is doing on treatment, by combining a static with a dynamic model like Leo score. Now, there is a head-to-head study of all these different models, static models. So this is an international study, over 3,000 patients from 11 countries. And as you can see here, on average, the male and the male sodium score seem to perform the best predictions for both 28 and 90-day mortalities. But it's important to know that substantial variations do exist between different countries. And I'm just giving a snapshot. Like I said, there are actually 11 countries here. It's also important to know that this study only looked at the static model. So it actually did not look at these models used in combination with a dynamic model like the Leo score. So technically, it's still maybe possible that if you combine the discriminant function with Leo, maybe it makes these differences that we see here irrelevant. We don't know that because they didn't actually study that combination used. But between different countries, you can see, France, for example, the male was not the best performer. It was actually the apex. So differences between countries do exist, and we have to be a bit careful about that. Now, beyond these standard models, there's also a recent study that it's made sense of what we see clinically, and that is, sometimes a patient can have all these really high scores saying they will do terribly, but you see them in front of you and they seem to be doing well, and it's because their labs seem to be improving, even though they're still technically in the severe or the high risk range for the prognostic models. So this study basically just verifies that, yes, in fact, if someone's bilirubin has been trending down, if they fall within the fast fallers category, which the study defined as day 7 bilirubin being less than 80% of the admission, the hospitalization value, then in that case, these patients don't seem to benefit from corticosteroids, regardless of whether they actually meet severe disease criteria based on the previous prognostic models or not. They just seem to be doing well. So this is another metric that may actually help us alleviate, avoid corticosteroid use. So just going over here to some of the medical therapies. We all know that abstinence is important, but abstinence alone is probably not enough in the short term. This study from France tells us that within the first 6 months, unfortunately, alcohol, whether or not someone is completely absent, was not predictive of mortality in the first 6 months. But instead, the baseline severity and the response to corticosteroid treatment was predictive. However, once someone gets beyond that, if you survive more than 6 months, then yes, long-term survival is largely based on or largely determined by ongoing abstinence or return to alcohol use. So that means it's important to know, how do we treat the hepatitis in the first 6 months? And there have been many theoretical pharmacologic targets that have been proposed. And unfortunately, many of these clinical trials have been negative to date. So really, the gold standard, the only treatment that has shown any consistent benefit over time has been steroids or prednisolone. The first randomized trial was in 1971. And initially, because the trials were smaller, they were a little bit inconsistent in the benefit findings. The classic teaching, though, is that we should be using prednisolone, not prednisone, which is prednisone is a precursor that requires conversion in the liver. So the theory was, if the liver is sick, you want to give them the active ingredient, not the precursor. Traditional teaching also says that prednisolone is not useful if Maddrey's discriminant function is above 54, and to avoid with these concomitant conditions like GI bleeding, pancreatitis, infection, and renal failure. But I wanted to talk about how some of these classic teachings are no longer true. sorry, this was meant to say that a lot of the reasons to avoid these conditions was because they were the exclusion criteria that went into the original study for the Madrid discriminant function score. So they have more of a historical basis to them. So, I mentioned that initial studies were a little bit inconsistent, but now after 50 years of research, yes, we think that corticosteroids do improve short-term survival in alcohol-associated hepatitis. And this is a meta-analysis of 11 trials of 2,000 patients. And that includes Stop AH trial, which was the single biggest trial published in 2015, showing that corticosteroid prednisolone compared to control does seem to be beneficial. But that benefit was within the first month. There was a decrease in mortality, 46% decrease in mortality within the first 6 months. Once you get to 6 months, though, within the first 1 month. Once you get to 6 months, though, there's no effect at that point. So it's a short-term 1 month mortality benefit. Now, because of that, the number needed to treat was actually only 13. And we just wanted to put this in context. The number needed to treat for using aspirin in ST elevation MI is actually 42. It's way higher. So this is actually a lot more, corticosteroids are actually a lot more effective, compared to what we think is very automatically the treatment for ST elevation MI. And we actually now don't think there is or we think that the cutoff for effective therapeutic window is a lot wider than what we thought before. In the study, steroids, again, they do decrease the 1 month mortality, but it's important to know that the survival benefit is where MELD is between 21 and 51, which is equivalent to Madrid score of way over 100. So no longer do we think that above 54 with Madrid is futile. The most effective range for the steroids is between MELD scores 25 to 39. And importantly, in the study, there was no difference between prednisolone or prednisone or IV methylprednisolone. They are all equally effective. So we don't think you have to, pick one. You can use all of them. If one is not available in your region, that's not a problem. And there may also be some benefit with IV N-acetylcysteine. This is a study in New England Journal in 2011. Unfortunately, the primary outcome for this study was 6 months survival, and you can see that it did not reach it did not reach the primary endpoint with a p-value of 0.07. But I say that's unfortunate because this study came out before the meta-analysis I showed several slides ago, where we now know that steroids only helps within the first month. It doesn't help at 6 months. So if this study were to have a do-over, if they had decided to make 1 month mortality as the primary outcome, they can see actually it was helpful at 1 month, pretty substantially comparing steroids with IV NAC against just steroids alone. It did seem to reduce the mortality within that first month. And infection was also less frequent in the group that used IV N-acetylcysteine. As I mentioned, recent drug trials for alcohol hepatitis really have not been all that successful. And the reasons for termination were anywhere between they were negative versus, they were terminated early because of possible hepatotoxicity. There are a few ongoing randomized trials, both within the US and internationally, that we're really hoping, will be helpful. But we don't have any data on their efficacy yet. So I'll just go to the next slide. It's important to also recognize that nutrition is critical in patients with severe alcohol-associated hepatitis. There have been several studies. Unfortunately, they're all small studies, but they largely have found that adequate nutrition is non-inferior, at least, to corticosteroids in severe alcohol hepatitis, both at 1 month as well as at 1 year. It's non-inferior. Now, I probably can't say that it's superior, but I will say that many times enteral nutrition has been found to have less infection than corticosteroids. So you can argue that, you know, it's non-inferior in efficacy, and it probably has less side effects, less adverse reactions. The only downside with enteral nutrition is that many of the studies require 28 days of NG2 feeding. So we don't technically know whether these results are reproducible by just encouraging people to eat. So lastly, as I mentioned, I'll briefly touch on liver transplantation, knowing about, recognizing some of the cultural differences between different countries. Alcohol became the leading indication in the United States in 2016. And you can see that before that, it used to be hepatitis C. But alcohol became the leading indication as the treatment for hepatitis C became very powerful in the last decade. And in 2016, alcohol accounted for a quarter of all the transplants in the United States. In 2017 and 2018, that trend has actually continued forward. Traditionally, there's a required alcohol-free period of 6 months around the world of 6 months before transplant. And the initial justification for that was that this 6-month period allows for recovery from the acute injury from alcohol. But really, and this initial justification, we're talking about 1990s. But over the last few decades, that practice has now become viewed as more of a protection, a prediction against post-transplant alcohol relapse. But the problem, though, is that has conflicting data. We don't, we haven't consistently been able to show that if you wait 6 months, then people don't relapse. And also, addiction medicine experts have uniformly not been supportive of such a practice. But most importantly, by requiring 6-month wait, it has made the liver transplant inaccessible for many patients with severe alcohol-associated liver disease who don't have 6 months of survival, who are have a very high mortality before them. So the landmark study from France showed that yes, proceeding to transplant before 6 months compared to not going to transplant offers a very significant survival benefit. And additional further studies then since then have come out in the United States and also in France. And this is our study here from Johns Hopkins showing that if you compare what we're calling the early transplant group, less than 6 months, or SLT, the standard transplant group, which is waiting for more than 6 months, you'll see that survival between the two groups are the same. You'll see that graft survival are the same, both at 1 and 3 years. You'll see that the relapse-free and the harmful drinking, hazardous drinking relapse-free survival are similar. The ELT group may be slightly lower, but it did not reach statistical significance both at 1 and 3 years, and both for any relapse as well as hazardous relapse. So we think that the two groups are very similar, and we think that the decision to wait for 6 months does not have a huge scientific basis behind it. Now, in our study, and this is our qualitative study, we wanted to get a sense for how were patients going into early liver transplant experiencing the whole process. And we found that they like to categorize their experience into 3 time buckets: illness or life before the illness, the severe illness that led to the transplant, and their recovery period post-transplant. And the life before severe illness, these themes were very similar actually to those with other, the SLT group, those with other alcohol-associated liver disease who did not go into transplant early. We found that the severe illness themes, so they often reflected the consequences of imposing the 6-month rule from the hospital system. So patients felt like they had to navigate the system on their own, and they felt alone. They felt isolated. But again, a lot of that was because of the system's barriers and not because of the disease process. And finally, in our post-transplant themes, many of our recipients define the transplant itself as a turning point for their ongoing absence, ongoing recovery from alcohol use disorder, which is very different than patients who already waited for more than 6 months before the transplant. But there's still many unanswered questions for early liver transplant, and that include how do you select candidates while still being fair to everyone? How do you monitor? How do you treat alcohol use disorder after transplant? How do you support their socioeconomic stressors? Many of our patients do note that they have some hard time going back to work, finding jobs. And finally, what are the general public's opinions of this practice? What are our colleagues, our medical provider colleagues' opinions of the practice? These are also some unanswered questions. So this is my last slide. In summary, alcohol is the most common cause for liver-associated mortality, especially among young adults. Severe alcohol-associated hepatitis has a very high mortality risk, especially if they do not respond to corticosteroid treatment. The primary treatment today remains corticosteroids, although we are hoping that there are some new medicines on the horizon. And finally, abstinence time by itself is not really a great criterion for deciding whether or not someone is eligible for liver transplant. I just wanted to acknowledge my collaborators here at the Johns Hopkins Delta Center for Alcohol Research, which is led by our transplant surgeon, Dr. Cameron, who is a field leader in early liver transplant for alcohol-associated liver disease. Thank you very much for the opportunity to share today.
Thank you, Victor, for a great lecture. So I think we can have like a 10 or 15 minutes, like a short wrap-up discussion to warm up the atmosphere, and then we can move next. So maybe I would like to summarize a little in Vietnamese for our participants, because some of us here are the hepatologists, but some of us are the postgraduate doctors. So maybe with a very comprehensive lecture, they would like to clarify more. Xin chào tất cả các bạn. Thì để thuận tiện cho việc trao đổi thì hôm nay chúng ta có buổi trao đổi liên quan đến bệnh lý gan mà do rượu. Thì bài của phó giáo sư Victor Trân vừa rồi cũng rất là hay, cung cấp rất nhiều các cái thông tin. Nếu như mà các bạn có câu hỏi gì, các bạn có thể hỏi bằng tiếng Việt hoặc bằng tiếng Anh. Thì ở đây có một số những cái key message mà mình cũng thấy khá là thú vị từ bài báo cáo này. Chẳng hạn như là điểm đầu tiên chúng ta có thể thấy ngay đấy là bác cũng có nói về câu chuyện là cái khái niệm về các cái đơn vị rượu sử dụng ở các quốc gia, ở các khu vực thì nó cũng tương đối là khác nhau. Cái vấn đề thứ hai là về cái diễn biến tự nhiên cũng như là gánh nặng của các cái bệnh lý gan do rượu, thì chúng ta cũng thấy rất rõ ở đây đề cập chủ yếu là đến vấn đề xơ gan và với chỉ định ghép gan. Vấn đề thứ ba được đề cập ở đây đó là trong cái thời điểm mà Covid vừa rồi thì rõ ràng là cái tình trạng sử dụng rượu và các cái biến chứng mà liên quan đến bệnh lý gan do rượu thì tăng lên rất là nhiều so với trước khi mà Covid. Liên quan đến vấn đề điều trị thì cũng rất tiếc là cho đến nay thì hiện tại cái corticosteroid vẫn là cái lựa chọn mà chứng minh được hiệu quả. Thế còn các cái thử nghiệm RCT với các loại thuốc mới thì hiện giờ vẫn đang cho cái kết quả âm tính. Và đối với các cái thang điểm thì chúng ta cũng quen thuộc với việc sử dụng các cái thang điểm, ví dụ như là thang điểm về đánh giá cái chỉ định ghép gan, như là MEL natri thì cũng là những cái thang điểm mà tại Việt Nam chúng ta cũng đã có nghiên cứu sử dụng, hoặc là cái thang điểm để mà mình đánh giá xem là liệu bệnh nhân như thế nào thì có chỉ định sử dụng corticosteroid, như là thang điểm liên thì cũng đã khá là quen thuộc. Thì nếu như mà các bạn nào mà chưa có nghe nói đến những cái thang điểm này thì hiện giờ thì chúng ta cũng có các công cụ rất là dễ dàng, hoặc là chúng ta có thể cài cái app QX ở trên điện thoại, thì vào trong phần hepatology nó cũng sẽ có những cái thang điểm cơ bản này. Còn nếu không thì chúng ta cũng có thể tra ở trên mạng, thì cũng có các cái ô để nhập các cái data vào, cho nên là đối với các bác sĩ thì hiện giờ cũng không cần phải nhớ một cách máy móc. Một vấn đề cũng rất thú vị liên quan đến câu chuyện là chỉ định ghép gan đối với cái nhóm bệnh nhân này thì bác cũng có nhấn mạnh câu chuyện là nó sẽ thường mất vào khoảng độ 6 tháng để bệnh nhân có thể phục hồi chức năng gan về cái mức ổn định, với cái điều kiện là bệnh nhân không có tiếp tục sử dụng rượu trong cái khoảng thời gian này nữa, thì sau đấy thì mới có thể có cái chỉ định ghép gan được. Thì đó là những cái điểm hết sức là sơ lược vắn tắt của bài trình bày. Thì không biết là trong Zoom ngày hôm nay thì có bạn nào có câu hỏi muốn đặt cho có thể là chúng ta đi qua 2 hoặc 3 câu hỏi để không khí sôi động hơn một chút cho các bạn đỡ buồn ngủ, và sau đấy thì chúng ta có thể đi đến một cái phần nhỏ, bởi vì bài trình bày của mình tiếp theo đây thì cũng tương đối là ngắn gọn, chỉ khoảng 15 phút thôi, và sau đó thì chúng ta cũng có trao đổi một chút với một đồng nghiệp rất là thú vị, đó là bác sĩ Phi, là bác sĩ ở chuyên khoa về tâm thần. Thì không biết có bạn nào có câu hỏi thì các bạn có thể đặt câu hỏi trực tiếp, hoặc là các bạn có thể đánh vào trong QA box. So firstly, I would like to raise a question for you, Victor, because it is very interesting when we think about the context of ALD, but we have to think a lot about the mental health of the patient, and that is why I re-invite Dr. Nguyễn Văn Phi, the head of psychology department of geriatric National Geriatric Hospital in Hanoi, to our webinar today. So one of the things I find very, very challenging in clinical practice is how to persuade the patients to stop using alcohol. And I think based on your lecture, we can see that during the COVID-19, the rate of using alcohol is increasing, and somehow it makes a burden for the ALD. So I want to ask, is there any kind of specific educational program for the ALD to support them to stop drinking?
Yeah, I definitely think you're absolutely right. My talk did not talk about the alcohol use disorder. That have a different talk for that. It's super important. And in terms of the education, I also agree with you that we, as the non-mental health practitioners, us on the internal medicine and the hepatology side, we need to learn more. It's not quite so easy because traditionally the training pathway is very different. And that's why, for me personally, I've tried to seek out different educational opportunities around the world even. And, there are these ECHO programs that are remote-based teaching programs that really began with hepatitis C, where a center of excellence and an expert center developed a model and helps people, in their community with how to treat hepatitis C patients. And that model, that educational model, has been translated now to several parts in the world, and the one that I participate in originated in India. The Indian Mental Health Institute is superb, and they have. It's not just alcohol. They have a entire educational series for substance use disorder, cocaine, cigarettes, and everything. But alcohol was one of them, and they have one for those who are tailored toward hepatologists. So that's one. We also know that that it's important to work in conjunction, ideally to work in conjunction with our addiction specialists. And in the United States, we that there are some systemic societal level barriers to that, but we also have found that around the world, because of different insurance structures around the world, it seems to be easier to have a clinic where you have mental health and you have hepatology, or you have internal medicine together. So it may be more doable in Asia, it may be more doable in Vietnam, but in the United States, that has been really challenging to put together. So that's why I do feel very important for us here for hepatologists to seek out additional educational opportunities.
Yeah, thank you. Câu hỏi của mình đặt ra cho bác Victor đấy là thật ra thì khi mà nói về điều trị bệnh nhân các cái bệnh lý mà gan do rượu ấy, thì một trong những cái vấn đề mà mình cũng cảm thấy rất là khó khăn đấy là một số những cái rối loạn tâm thần kinh, cũng như là cái việc làm sao mà để thuyết phục bệnh nhân là không có sử dụng rượu nữa, thì liệu là có các cái chương trình về giáo dục nào mà phù hợp với nhóm bệnh nhân này không? Thì bác cũng có trả lời là có một cái chương trình chắc là mọi người cũng nghe rồi, đặc biệt là nếu mà ở đây có các quý đồng nghiệp nào mà đến từ nhi ấy, tại vì theo như mình biết thì ở bên nhi khoa các cái chương trình của ECO đã vào bệnh viện nhi trung ương triển khai rất là tốt. Thế thì ECO thật ra là một cái chương trình mà ban đầu phát triển là dành cho bệnh nhân viêm gan C. Thế thì sau đấy thì nó cũng có thêm các cái module đào tạo từ xa cho các cái bệnh lý khác về gan. Trong đấy là có cả một cái mảng là về viêm gan do rượu. Thì đó cũng là một cái kênh mà để mình đào tạo trực tuyến từ xa, đặc biệt là cho giáo dục cộng đồng. Vấn đề thứ hai đó là vấn đề liên quan đến cái người mà có thể ở Mỹ thì sẽ có các cái bác sĩ mà chuyên về tâm thần, rồi chuyên về nghiện chất, người ta có thể điều trị cho bệnh nhân. Và có cái mô hình nếu như mà đối với các phòng khám ấy, mà phòng khám mà có cả bác sĩ nội khoa, bác sĩ gan mật và bác sĩ ở bên tâm thần kinh mà có thể phối hợp với nhau để mà quản lý theo dõi bệnh nhân thì thường là nó sẽ hiệu quả hơn. Tuy nhiên thì đương nhiên là ở mỗi nơi trên thế giới thì sẽ có các cái cách tiếp cận nó cũng tương đối là khác nhau. Có thể là chúng ta sẽ dành một ít phút để say hello với bác sĩ tâm thần của chúng ta và nghe một vài ý kiến của bác sĩ trước khi mà chúng ta chuyển đến phần tiếp theo. Hello Dr. Phi. So please say hello to our participants and give some comments about the topic we raised.
Okay, so very nice to meet all of you. And I totally agree with you that it's a really difficult problem. Because in Vietnam, like US, in Vietnam, the alcohol use disorder is the most common mental health problem. In National Investigation of Vietnam in 2010, we investigate the prevalence of 10 most common mental health disorder, and the alcohol use disorder is the first with 5%. In US, the addiction specialists are responsible for treating alcohol use. But in Vietnam, we have no addiction specialist, where those psychiatrists like me will responsible for this problem. But there's a very big problem is that when the patient, the alcohol use patient come to meet us, so normally most of the case are very severe case with the really bad consequence of the physical, for example, the CO. So I think the problem is that we lack of the multi-specialty coordination. So, for example, the internist or maybe the internal neurologist like Dr. Han here, we could have a little training in substance use and mental health disorder. And so when you focus on when the patient come with you, you focus on the problem, for example, with the hepatitis, for example, and after that you send patient to home. Normally you didn't send the patient go to meet the psychiatrist, so the patient lost the chance to get the chance for intervention, for early intervention, and to help them to quit the alcohol. So I think maybe in Vietnam now we lack one effective program for alcohol use disorder. Maybe it's come from a lot of reasons, but the most important reason, in my opinion, is we lack of the multidisciplinary team, like one psychiatrist and hepatologist and internal doctor. So I think maybe in the future, maybe it's if we can base on one program, we can get some grant to organize one team like that to create maybe the guideline because in our domain mental health, we can provide the patient some technique like motivation interviewing to help them how to motivate to quit the alcohol. But how to connect between the specialists is the most important. So we can create one team like that. Maybe if Hằng can lead for this program. So that's my idea.
Thank you, Dr. Phi. I think you have to lead that team, not me, because in fact, I don't know how the physicians in the US do the clinical practice, but sometimes when the patients come to us, maybe we focus so much on the liver functions and on the complications and for the follow-up journey. And I think the only thing I can do is to explain to the patients about the benefits and the risk if they still keep continuing drinking. But I think I'm still lack of many skills. For example, I haven't heard about the motivation interviewing, as you said. So I think one habit we can try now is maybe to classify the subgroup of patients that can have the benefit of the psychology interventions. So it will be the first step if we can target what kind of patients like that. Maybe it is the first step how we can transfer the patients to you. So now please we have the opinions from Doan and then Victor. Please go ahead.
Thank you, Hằng. I just have a question to Victor. In Asians, many of us, after we drink alcohol, we turn red. It's a flushing syndrome. Does that have any clinical implication? Are they at high risk of developing liver diseases?
Yeah, no, I'm happy to answer that first. So that is what you're referring to is a decrease, it's a mutation in the acetaldehyde dehydrogenase gene, ADLH. But yes, what happens is in Asian, we're more likely, more of us are unable to process acetaldehyde to aldehyde. And aldehyde is great, but acetaldehyde is a problem. Acetaldehyde is a free radical where it makes you really sick, flush. You could also be nauseated. You could also just feel terrible. So that part actually is protective against alcohol use disorder. But if you push through, if you fight through it, then the acetaldehyde becomes a risk for developing liver fibrosis, liver cancer, everything. So it's both protective and it's bad for you if you ignore the warnings.
Wow.
But I also would like to add to the concept of referring. So one thing that we try to emphasize clinically, and I'm hoping to reproduce on a research side is, I think internal medicine and hepatologists have the opportunity to practice what we call SBIRT, which is screening, brief intervention, and referral to treatment. Now, screening is important. Here we're just talking about alcohol-associated liver disease. But in reality, it's not always so easy because somebody may come to you and they are described as having NASH or they're described as having hepatitis B. But actually, if you don't ask, you don't realize that, you don't screen, you don't realize that actually alcohol is also a big part. So screening is very important. Without that, nothing else matters. But once you identify someone, another take a step back. There are many screening tools out there. There's the WHO's audit score, which is only 3 questions. But in the US, we even promote the 1 question. Have when's the last time you had any alcohol? Even just 1 question is better than nothing. So that's screening. Now, brief intervention, in the ideal way, you do want to use motivational interviewing techniques. But even if you don't do that, just being more cognitive, just choosing one item in what patients tell, just one item and just discuss that one item, give no more than 5 minutes or less, no more than 2 minutes, just one item each visit already slowly pushes the boundaries. And then finally, of course, once because we are ultimately not psychiatrists, so referral to care is helpful, but that relies on having the system in place.
Yeah, very interesting. Vừa rồi thì các panelist cũng đã có một số cái trao đổi rất là thú vị. Thì hy vọng là các bạn cũng có thể dõi theo được cái trao đổi vừa rồi của chúng tôi. Thì cũng xin phép được nói ngắn gọn lại một chút mấy ý. Bác sĩ Phi thì cũng có chia sẻ là ở Việt Nam thì hiện giờ chúng ta cũng đang thiếu các cái hướng dẫn, cũng như là trong thực tế thì cũng không có cái sự quan tâm đúng mức đến cái việc là các cái rối loạn tâm thần kinh ở bệnh nhân mà bệnh gan do rượu, mặc dù là trong cái danh sách 10 cái bệnh lý mà rối loạn tâm thần kinh thường gặp nhất ở Việt Nam thì các cái rối loạn liên quan đến rượu là đứng đầu tiên, chiếm tỷ lệ đâu đó hình như bác sĩ Phi nói là 5%, đúng không ạ? Thế nhưng mà rõ ràng là điều này cũng đặt ra một số những cái thách thức và cũng đặt ra cái cơ hội là chúng ta cần phải làm việc nhóm với nhau nhiều hơn. Sau đó thì chúng ta đến với câu hỏi liên quan đến việc là người châu Á thì hay có cái đỏ mặt sau khi uống bia rượu, thì liệu là nó có liên quan gì, nó có phải là cái cơ chế phòng vệ đối với cơ thể của chúng ta hay không? Thì bác Victor cũng có trả lời là đúng là nó ở người châu Á thì hay gặp cái tỷ lệ này của phát sinh này nhiều hơn là bởi vì chúng ta có cái đột biến gen ALDH. Tuy nhiên thì nó là một cái cơ chế phòng vệ, nhưng mà nếu mà chúng ta vượt qua cái cơ chế phòng vệ này, tức là coi như chúng ta kệ nó mà cứ bệnh nhân của chúng ta coi như là đỏ mặt vẫn uống ấy, thì lúc đó thì nó sẽ vẫn tiến triển đến những cái biến chứng sau này như là xơ gan rồi ung thư gan. Và cái ý thứ ba rất là hay mà bác Victor cũng có tóm lại ấy, đó là khi mà bởi vì bác sĩ Phi cũng có nói đến một cái một cái gọi là motivation interview, là phỏng vấn tạo động lực, đúng không ạ, là một trong những cái can thiệp mà chúng ta có thể sử dụng đối với người bệnh. Thì bác Victor cũng có gợi ý là thật ra trong thực tế, nếu như mà nói là để mà quản lý những cái bệnh nhân này thì có thể có 3 cái keyword chính mà chúng ta nhớ. Một là sàng lọc, có nghĩa là khi bệnh nhân đến, nếu như mà chúng ta chỉ hỏi những câu hỏi rất đơn giản như là có uống bia rượu không, và đôi khi bệnh nhân của chúng ta đến mà chúng ta nhìn thấy là có gan nhiễm mỡ, mỡ máu cao hoặc là có viêm gan B rồi, thì đôi khi là chúng ta quên mất cái câu chuyện sàng lọc này. Chúng ta nghĩ là ok, vậy là nó liên quan chủ yếu đến cái vấn đề viêm gan virus hoặc là ở gan thoái hóa mỡ do rối loạn chuyển hóa, chứ chúng ta quên đi mất cái câu chuyện là bệnh nhân có sử dụng bia rượu hay không và sử dụng với lượng bao nhiêu, tần suất như thế nào. Thì cái đầu tiên mà chúng ta cần nhớ đó chính là cái vấn đề liên quan đến sàng lọc. Cái vấn đề thứ hai đó là vấn đề mà liên quan đến câu chuyện là làm thế nào mà để mình tạo ra được động lực cho người bệnh ấy, để mà người ta ngừng sử dụng rượu ấy. Thì thật ra là theo những kinh nghiệm của bác thì chúng ta cũng bởi vì chúng ta cũng không phải là bác sĩ chuyên khoa về lĩnh vực này nên là có thể chúng ta không thể nói quá dài được, nhưng mà chúng ta cũng nên có cái trao đổi rất là trọng tâm với người bệnh, không nên quá dài, quá 5 phút vì có lẽ là người bệnh của chúng ta cũng không thể nhớ được, nhưng mà cũng không nên ngắn quá, nếu không thì nó sẽ trở nên là hơi hời hợt. Nhưng ít nhất là chúng ta sẽ chọn ra một cái điểm nào đấy mà chúng ta thấy là có thể nhấn mạnh để thay đổi được hành vi của người bệnh. Và vấn đề thứ ba đó là chính là cái vấn đề là chuyển đến chuyên khoa khi cần thiết. Nếu như chúng ta thấy là người bệnh của chúng ta thật sự cần cái sự tư vấn từ các bác sĩ chuyên khoa tâm thần, thì chúng ta nên gửi người bệnh trực tiếp đến các bác sĩ chuyên khoa tâm thần để người bệnh có thể được nhận cái sự chăm sóc y tế từ cả hai bên một cách toàn diện. So now maybe I will move to my presentation. I hope that it is not long because I prepared a very short presentation to introduce about the situation in Vietnam. Bây giờ thì cũng xin phép các bạn là mình sẽ có một bài trình bày rất là ngắn gọn liên quan đến cái thực trạng mà sử dụng rượu tại Việt Nam, và chắc là vì bài này ngắn thôi nên là và cũng rất là dễ hiểu nên chắc là mình sẽ xin phép vào tiếng Anh, để sau đấy thì trao đổi với bác Victor nó cũng tương đối là liền mạch, bởi vì chúng ta cũng muốn đặt các cái câu hỏi mà nó có tính chất để liên quan để cho mọi người có thể hiểu và trả lời cho nó nhanh. So I moved to my presentation about the current situations of ALD in Vietnam. So there is a fact, a very upset fact by WHO about the consumption of alcohol in Vietnam, and it is increasing sharply. You can see that in Vietnam in 2005, the APC is only like 3.8, but until like 10 years later, it is like 77%. increase. So that is one thing that we have to consider, and it is much more comparing to the number of the world. And in 2017, Vietnam is one of the 3 countries in the Southeast Asia has the highest alcohol consumption. I think that this data is like nothing too proud, but it is like a red flag we have to think about. And sometimes, as you say, that maybe because Vietnam has the high prevalence of viral hepatitis B, so sometime and somehow it makes the physicians low, like we a little like evaluate the situation of alcohol liver disease a bit lower than the reality. And in 2021, there is a study on a very survey on the more than 2,000 people, and we found out that more than 60% of the men currently drink alcohol, and in which nearly 15% of them drinking at a dangerous level. So in the last month, at least one time drink of more than 6 alcohol units. And another survey is on more than 5,200 respondents from 12 provinces conducted in 2015 showed that the prevalence of alcohol consumption is very high, especially in the central of Vietnam. And in this study, they performed the study because like in the 12 provinces, they chose the 12 villages. In the 12 villages, and then they will choose like the 12 household and then take the records. Another very interesting paper published focused on the ethnic minority group, because in Vietnam, the majority group is Kiến, and then we have many multiple ethnic minority groups, especially in the mountain area. And in this study about tobacco and alcohol use, it seems that the prevalence of using alcohol was around 30% in the ethnic minority group and higher in men. And there are several factors associated with alcohol use, such as the middle age, the lower education, the employed, no religion, or live with other drinkers. And there is one thing that is very special regarding to the Vietnamese culture when drinking alcohol is that more than 60% of the alcohol consumption are the handmade alcohol, not the commercialized one. And beer is also consumed a lot. And I think all of us know that Vietnamese people love beer. We have a lot of kind of beer, especially the draft beer. And about 50% of the commercial alcohol is consumed in the drinking occasion. From this study also, one more emphasize still homemade alcohol or alcohol without brand are the most popular one. So how about the difference between the urban and the rural areas in Vietnam? So this is a study, like a cluster studies, and it showed that the proportion of the men who drank 2 or 3 times per week was more than 50%, and most of them are the married men. And when we use the audit score, we found out that more than 20% of them have the audit from upper 8. And what happened with such kind of context of using alcohol? So we found out that this is the data from the world that's showing that alcohol was the second cause of liver cancer. And coming back to the data of Asia, it is also very clear that ALD was higher in men comparing to women, and contribute to the progression of liver cirrhosis and liver cancer. However, for the international publication only for Vietnamese population, the data is still limited. But somehow when we try to find out, what we found out is a little upset that there is one publication in 2023 about the chronic liver disease showing that Vietnam is the fastest increasing incidence rate of alcohol-related cirrhosis in global based on the age standardized rate. So in Vietnam, liver cancer ranks number 1 in the prevalence and mortality of liver cancer. We have 8% of HBV, and now we have the fastest increasing incidence rate of alcohol cirrhosis. So all of such kind of data raise red alarms to all of us. About the domestic data, we have several studies about alcohol use in liver cirrhosis patients. For example, this is a study on 952 patients. They are the high-ranking officers visiting the military hospital in 1 year. And more than 50% were frequent drinkers. And of course, the excessive alcohol consumption increased the risk of liver fibrosis by 3.8 times in this study. Another study in the northeast of in the people living in the northeast of Vietnam also this study compared the patients with the alcohols and the healthy patients, and also show that there is a very clear difference between the liver enzymes, between the liver functions, between the two subgroups. And how about liver cirrhosis? Bạch Mai Hospital is one of the biggest hospital managing the liver cirrhosis patients in the north of Vietnam. Is this okay?
Mm-hmm.
Okay, and then in this study, also showing that nearly 70% of the patients use alcohol within 3 months before the admission. And we can see that besides the upper GI bleeding, such kind of patients also have other complications such as infection, hepatic encephalopathy, or liver cancer. And that is why when we think about the liver cancer, as I said, Vietnam is in the region with very high prevalence of liver cancer. And according to one study, it showed that alcohol consumption is also the leading cause of liver cancer in Vietnam, comparing to other etiologies. So when we check about the domestic data, we also, this is a study in the north of Vietnam in the 3 major hospitals with nearly 200 advanced HCC patients. And it showed that around 30% of the patients use alcohol, and in which like half of them are combined alcohol and viral hepatitis. Another study from the south of Vietnam also pointed out that drinking alcohol occurred in nearly 70% of the patients who received the surgery and a liver transplant. So this is very interesting when we think about the overlapping between our field and other colleagues, like we just raised the topic when we talk about QA, alcohol and mental health. So this is a study from the psychology colleague, and they checked about the comorbid disease of the patients with disorders, the psychology disorders, when using alcohol, and it showed that more than half of the patients have the alcoholic liver disease, and in which 20% are liver cirrhosis. Another interesting paper I want to introduce is a prospective study on 53 patients. They are the alcoholic patients, and they have received the treatment in the National Psychology Hospital in Hanoi. And they will follow up after 1 month, 3 months, and 6 months to check how many of them will have the relapse, how many of them will use the alcohol again. And 81% of them used the alcohol again, in which half of them used in the first month. And the most common reasons is that nearly more than 80% said that it's just because it is very easy to buy the alcohol. The availability in the market is so easy to take one. So that is the most common. And the second thing is that they miss the feeling of drinking alcohol, also more than 70%. So this is somehow make us consider about. That is why I raised the question on education program, also on the interventions of the psychologists here, because with this data, we can find that it is very, very, very challenging when we, because all of these patients have received the treatment in the most upper level of healthcare system in Vietnam, but 81% failed when we follow up. So I think we, as Dr. Phi said, we have to think about something like a more comprehensive and effective program. Another thing we have to think about is the malnutrition, because in Vietnam, most of the patients, when they drink alcohol, they often eat little. So that is why the patient, when coming, they often have the muscle wasting and they can have the malnourished. And in this study, they have 77 patients ALD, and they found out that more than 25% having the malnourishment, and in which more than 90% in the moderate to severe levels. Another thing that is also often occurs in Asian countries, especially in Vietnam, is the poisoning. Because as I mentioned before, many of the people love the homemade alcohol or the no-brand alcohol. So that is why sometimes we have the alcohol poisoning cases. And it can occur in all the regions in Vietnam, but it is often occur more frequently in the important occasions of the years, and it is often occur due to the methanol. So just have some take-home message. ALD is common in Vietnam with many complications, but in which liver cirrhosis and liver cancer are the most prevalent. In our context, the combination of alcohol and viral hepatitis makes the burden to the complications. And other issues relating to ALD still challenging in our country, we can consider is mental health management, nutrition, poisoning, and as Dr. Phi mentioned previously, we should think about the multidisciplinary approach. So thank you, and we'll go back to the QA discussion.
Thank you, Hằng. While we're waiting for questions to come in, this is a question to you all. If you can share your experience regarding alcohol biomarker use in screening and diagnosing alcohol use. Is it available in Vietnam? And Victor, also, if you can share the experience in the US. As you know, a lot of patients who drink alcohol, they often minimize or don't report. Thank you.
Yeah, so this is true because sometimes when we ask the questions, many of the patients don't tell us the truth. So so I often also check some other biomarkers such as GGT is one, or MCV. If I saw the MCV more than 100, and also elevated GGT, and also if I check and I see that the patients have the hepatomegaly, and also in the ultrasound we saw the fatty liver. So all of this in the context, and especially in male patients, middle age. So all of this will make me think about maybe he is using alcohol. And in fact, I don't know about how you manage in the US, but in Vietnam, if I ask the patient that, do you drink alcohol? Sometimes the patient will tell me, are you kidding me? Every man drink alcohol. So that is like the concept of the culture. So sometimes I have to try to classify what is the level that is really alarming in this patient.
Thank you, Han.
Yeah, I'll also mention, in the U.S. Until recently, we were largely relying also on what Han, you mentioned. These are the indirect markers of alcohol use, with certainly with the MCVs, and then we can do the AST-ALT ratio. GGT has been around for a very long time. In fact, is our insurance company's favorite test to use because it's so inexpensive. But of course, the issue with GGT that often comes up is alcohol can raise it, but so can liver disease from any other disease. So we get consults or referrals for from the insurance company sometimes of these, and it's not always alcohol. More recently, we've gone to what we call direct markers of alcohol use, and classically it's just serum ethanol. But of course, the problem with ethanol is it disappears. The metabolism is so fast, and we care more about we care less about the last 12 hours and more about the last 3 or 4 weeks. So the one test that sort of came on the market about, I would say about a decade, 5 to 10 years ago, is something called a carbohydrate deficient transferrin, and it's actually pretty good. Except we use it now less in patients with cirrhosis and who are facing transplant, because it doesn't perform very well once the liver disease is really bad. But up until that point, it's not a bad test, and it's also relatively less expensive. And now in the transplant world, we are using a lot more what's called phosphatidylethanol, which is a metabolite. It's a phospholipid that ends up on the red blood cell as a result of exposure to ethanol. And there are different isoforms, but the bottom line is that because it's tagged to red blood cell, it can still be detectable. The half-life is anywhere between 4 to 6 days, and it can remain detectable in individuals with at-risk drinking for up to 3 or 4 weeks. So that's what we use now, but it's still relatively new, and not every facility has it, and the testing takes a while to come back, about 7 to 10 days. So it's not a perfect system yet.
Thank you. That's really helpful.
Can I also mention, I wanted to ask, I was surprised by how much homemade alcohol, is in Vietnam, and I may be naive. I don't feel like in the US, what we call moonshine is as big of a group as people who drink beer. Maybe because beer is everywhere and it's inexpensive. I don't see it as often. But I wonder if you can comment on why you think in Vietnam home use is so high, because that alarms me a little bit. Like all of the things that we just talked, all the biomarkers, none of that measures methanol. So that worries me a little bit that none of that works. So yeah, I'm just kind of curious, why is it so often?
Yeah, I think it is maybe after this webinar I will send to you, because I have read one manuscript very interesting about the culture of drinking alcohol in Vietnam. It has published several years ago, and in which they also explain about why the Vietnamese patient like to cook alcohol by themselves. But maybe the first thing is that some of the because we have so many mountainous area, and in such kind of rural areas, it is it can be very cold in the winter, and it is very far, so it is very hard to buy the beer or to buy the commercialized product, and it is somehow expensive for them. But for the people in the rural area or in the mountain, they can cook by themselves because it made from rice, and rice is very, very like available in the common life. And the other thing is that Vietnamese people are very love the herbals. Like they can put the we call it like the natural enzymes from the leaves. There will be like many different types of leaves, or sometimes they will put some insects or some other things into the alcohol, and it will make the taste of the alcohol also very different. So that is why they love to make the home cooked wine. And in Vietnam, there are so many traditional occasions like a wedding. Sometimes they drink for the whole week, or the traditional lunar calendar, they can drink for the whole month. So that is why if you buy wine, the commercialized product, it will be very, very expensive. But if you cook by yourself, it will be much cheaper. So I think that is about the economics, and that is about the culture. So coming back a little, because
yeah, I want to explain a little about the home cooked alcohol, because it here maybe somehow you understand that maybe the people drink alcohol that they cook by themselves. But normally in the village, because I come from the village, the one house, one traditional alcohol produce will cook in their house. Maybe it's one village. There are two or three or some home cooked produce, and they cook the alcohol and sell to other people. And because it's really cheap, it's around maybe it's 50 cents per liter. So it's very easy to approach. So that's one reason they can easy to buy. For easy to approach for the Vietnamese people. And in terms of the level of the alcohol use, that we should send to the patient to meet the psychiatrist. I have a comment here. That's maybe the internet the doctor like you, maybe you care about the level of the alcohol that the patient drink. But for me, I'm psychiatrist. I care about how the patient depend on and how a patient craving when they stop using the alcohol, because it's the risk factor that the patient will come back, will relapse the alcohol. So
yes,
so
thank you, yeah.
maybe we can use some skill, because we have a lot of skill to count what's the how the patient depend on the alcohol, and we can count the cutoff point to decide when we will send the patient to the psychiatrist.
Thank you, Dr. Phi. And I want to come back a little about the question of Dr. Doãn, and then we can translate a bit for the audience. Hồi nãy thì có một câu hỏi rất là hay liên quan đến câu chuyện là có cái biomarker nào mà liên quan đến mà mình có thể giúp phát hiện các cái bệnh lý gan mật mà do rượu hay không? Thì bác cũng có chia sẻ là những cái chỉ số, ví dụ chúng ta có thể dùng những cái rất cổ điển, ví dụ như là chỉ số giữa AST trên ALT, GGT vân vân, nhưng mà hoặc là MCV, nhưng mà GGT thì bảo hiểm bên đó thì rất là thích bởi vì là rẻ, nhưng mà chúng ta cũng phải nhớ là GGT thì ngoài cái tăng trong bệnh lý gan do rượu thì nó cũng tăng trong các cái bệnh lý gan khác, nên là thật sự thì nó cũng không có đặc hiệu. Có một số những cái chỉ số khác có thể sử dụng, ví dụ như là hồi nãy thì bác có đề cập đến hai cái chỉ số, nhưng mà có lẽ ở Việt Nam thì cũng chưa có, hoặc là cũng cũng không biết là các đồng nghiệp có biết hay không. Đó là một cái là cái carbohydrate deficient transferrin ý, CDT, và một cái đó là PETH ý, là cái chất chuyển hóa của rượu. Nhưng mà đương nhiên thì những cái biomarker này thì nó cũng không có thông dụng ở trong lâm sàng. Và cái nữa là khi mà người bệnh của chúng ta mà đã rất là nặng rồi ấy, ví dụ như là đã ở giai đoạn ờ, xơ gan hoặc là có các cái biến chứng rất là nặng rồi, thì thật ra những cái mà liên quan đến vấn đề các cái biomarker chuyển hóa nó cũng không còn thật sự là có ý nghĩa nữa. Có vẻ hôm nay các panelist thì trao đổi rất là sôi nổi, nhưng mà chưa thấy câu hỏi từ các quý vị khán giả, thì tranh thủ chúng ta có thể là còn khoảng độ 5-10 phút nữa là kết thúc webinar. Thật ra hiện tại thì chúng ta cũng đang hơi quá giờ một chút, nhưng mà bởi vì chúng tôi chưa nhận được bất kỳ câu hỏi nào từ các bạn quý khán giả, nên là cũng rất mong là các bạn có thể chia sẻ, có thể là chia sẻ ý kiến, kinh nghiệm cá nhân, hoặc có thể đặt một số câu hỏi cho các báo cáo viên của chúng ta. Ở đây chúng ta có bác sĩ tâm thần, không phải lúc nào cũng mời được đâu ạ. Rồi chúng ta có một báo cáo viên rất là nổi tiếng ở John Hopkins, thì rất hy vọng là nếu như chúng ta có một câu hỏi nào đấy trong thực hành lâm sàng, hoặc là khi đọc ở đâu đó mà cần trao đổi, thì chúng ta có thể tranh thủ một vài phút sắp tới để trao đổi tiếp trước khi mà chúng ta close cái phiên ngày hôm nay. So while waiting for the response and for more question if having, one more question I want to ask you regarding to the liver transplant. Is there any difference in the prognosis between the alcoholic liver disease indication and the viral hepatitis indications for liver transplant?
And let me just clarify, when you say prognosis, do you mean before the
Yeah.
transplant or afterwards?
After the transplant.
Okay. Yeah. So there is a difference. We've actually found, probably not that surprising, we've actually found that patients with alcohol-related disease do great, probably better. Now, there's a little bit of, we have to adjust for things, right? Because with alcohol-related disease, the patient population tends to be younger. So that already, I think, is a survival benefit for transplant. Whereas with hepatitis B, especially if you're talking about cirrhosis or hepatocellular carcinoma, that becomes much more common 50, 60 years old. So that's, I think, a big difference. And the other big difference is, while chronic alcohol use can and frequently does cause malnutrition, that is true. But for whatever reason, those who develop alcohol-related hepatitis, they're not all malnourished. And I don't have a good way of saying, figuring out why there's a difference. But people who, this is not cirrhosis, this is people with the acute hepatitis. They're not all malnourished. And many times for those patients, their one medical issue is their liver failure. They don't have they don't have cardiovascular disease. They don't have all the other diseases. They have liver failure. So it also means that their post-transplant course tends to be smoother than someone who already has, strokes and all these other histories.
Yes, thank you. Câu hỏi mình cũng vừa đặt cho bác đấy là liên quan đến cái tiên lượng sau ghép gan giữa nhóm bệnh nhân mà do các cái bệnh lý gan do rượu với nhóm bệnh nhân mà viêm gan virus ý, thì nó có khác nhau không? Thì câu trả lời là có vẻ như là cái nhóm bệnh nhân mà do rượu ấy thì nó sẽ tốt hơn. Lý do là bởi vì thường những cái nhóm bệnh nhân này trẻ tuổi hơn thì sẽ ít các cái bệnh đồng mắc hơn, thì bản thân tuổi nó cũng đã là một yếu tố mà đóng vai trò khá quan trọng. Vấn đề thứ hai đó là đối với những cái bệnh nhân mà đôi khi là người ta suy gan cấp ý, có chỉ định ghép gan vì là suy gan cấp, nhưng mà chỉ là do suy gan cấp thôi, Còn không có các cái bệnh lý gì khác thì nó sẽ khác so với việc là một cái bệnh nhân suy gan nhưng mà lại ở trên nền bệnh mạch vành hoặc là bị đột quỵ chẳng hạn, thì chắc chắn là cái hồi phục sau khi mà ghép gan ấy, thì nó sẽ khác. Dr. Doãn, do you want to like have some words to wrap up? I think we have a very interesting webinar today and a lot of the discussions among the panelists.
Yeah, thank you, Professor Hằng again, Dr. Victor Change and Dr. Phi. I thought it was pretty educational and hopefully it was relevant to the audience. Thank you for the participation. I think we over time, so until next time, I wish you all a wonderful night now in Vietnam. It's an evening in Vietnam. So thank you again.
Yes, so thank you a lot, Victor, for your great talk and a very comprehensive, informative discussion. We like it a lot. And thank you, Dr. Phi, for coming to the hepatologist. Maybe you will think that sometimes we have a very little experience on how to intervene for the lifestyle habit of the patients, and we want to learn a lot from you, from your experience. And as the previous level talk, we are very happy to welcome all the participants. Besides the knowledge, we really want to create this event as an educational activity and a forum to exchange experience, because we will see that the clinical practice sometimes is not as the guidelines. It is very different in the different regions, and it is different from the Western and the Asian. And somehow from these events like Liver Talk, we hope that we can create some ideas. You can change some very minor habits in your clinical practice, or you can think about some kind of research idea that you want to expand in your team. So that is the success of Liver Talk. And I hope that you have a great night today. Thank you all the panelists for coming to Liver Talk today. Thank you the support from BVHA, from IGA, from the technicians who all support for this event. And thank you all the participants to join with us, and see you very soon in the Liver Talk next episode. Thank you and goodbye.
Thank you.
Yeah, thank you.
Thank you very
Yeah,
much.
thank you. Bye bye, Victor. See you. Bye anh Doãn. Bye Phi.
Yeah,
Thank you.
bye. Bye anh Doãn. Bye chị Hằng nhá.